to introduce Dr. Angel Algarin. He is currently an assistant professor at Arizona State University. He completed his MPH at the University of Kentucky and then went on to do his PhD at Florida International University. And he's had a really fantastic career, already has a 5-year sponsored K award from the National Institute on Drug Abuse. And he has been mentored by Dr. Laramie Smith for the last number of years and who's continuing to collaborate with him. So he's going to be talking about some of his research today. We're looking forward to hearing from him, aren't we, Benita?
Thanks so much for that introduction, Dr. Strathy. And thank you, everybody, for your attendance. So today I'm going to be talking to you about the Encuesta de Sexo Entre Hombres study, and a little bit about the findings from this national sample of men who have sex with men in Mexico, and how some of these findings can inform policy and intervention. So as Dr. Strathy mentioned, I'm currently an assistant professor at Arizona State University's Edson College of Nursing and Health Innovation. I also have an affiliation with the Center for Health Promotion and Disease Prevention. My work with the Encuesta de Sexo Entre Hombres study, or as we call it, essay study, started when I started my T32 postdoc at UC San Diego. And I started working with Laramie Smith on this project. And it was one of the first projects that I started to get my hands dirty with some data. And so I'm really excited to be able to show a little bit about the project, an overview of the results that have come from the project, and a little bit of an overview on how we feel like the results can inform policy and intervention. So I'd like to take this as more like an amuse-bouche to the results, and for further details, definitely refer to some of the papers, or if you have additional questions, I'd be happy to answer at the end. So, sorry, I now notice I'm not sharing my screen.
Yes, I was just about to remind you.
Thank you for reminding me. Okay, so I think everybody can see that now. So a lot of these results were not just from me. It was from a whole team that preceded me and is continuing to go on as we proceed. So I'd like to thank our essay core team, which was comprised of the two co-PIs, Dr. Mauricio Hernandez Avila, Dr. Laramie R. Smith, Ricardo Baruch, Travis Sanchez, Marisol Valenzuela Lara, Joanna Chapin Bardales, and Maria. These folks really have made the core of the team and have really helped shape the methodology of the study. And so this project was funded through the San Diego Center for AIDS Research under an international pilot program. And so I wanted to make sure I got those acknowledgements in. So a little bit of background. So before 2013, the prevalence of HIV among men who have sex with men was estimated around 10% in Mexico. But in 2013, the cross-sectional study published by Batista Arredondo across the nation of Mexico found that the estimated prevalence was actually probably closer to 16.9%. And so this is the graphic or map that was produced by this article, and you can see they surveyed areas and metropolitan areas in different regions of Mexico. And the ranges of the regions range from 20.4% here in the Central East region, which was inclusive of the city/state of Mexico, all the way to 9.9%, which is here in the Central West region, which has cities such as Puerto Vallarta. And so this difference between that 10% that was previously estimated and that 16.9% that was estimated from the 2013 article was that lack of large-scale epidemiologic studies in the country largely contributed to this underestimation of HIV burden in Mexico, highlighting opportunity for surveillance expansion. And so while men who have sex with men are a key HIV risk population in Mexico, the majority of the research on this population has taken place primarily in the capital city of Mexico City. So having large national epidemiologic data sets are helpful for informing policy and intervention decisions on a national scale. So to fill this gap, researchers from la Escuela de Salud Pública de México, el Instituto Mexicano de Seguro Social, Emory University, and the University of California, San Diego, conceptualized the Encuesta de Sexo Entre Hombres and received funding, again, through the San Diego CFAR International Pilot Grant Mechanism. So a little bit about the study design. The Encuesta de Sexo Entre Hombres, I'm going to just refer to it as essay from now on, is based off of the AMIS, American Men's Internet Survey, an online serial cross-sectional in the United States. AMIS is run through Emory, and they also have other studies that they run through, not only just in the United States, but in Europe. They have an iteration in Latin America, and they also have iterations in Africa as well. And so these studies are completely online, and they seek to recruit men who have sex with men in their respective countries to monitor sexual behaviors and HIV prevention practices. So for essay, our recruitment strategy was that we recruited over 11 weeks between May and July of 2017, using websites identified by MSM community members. And so 2 of these websites included just typical Facebook, Twitter, those social networking applications. We also found 2 websites that were Mexico and gay kind of specific, which are Soy Homosensual and Desastre. And then we also found that Grindr and Hornet, which are geosocial networking applications, primarily used by men who have sex with men to either find sex partners or other men who have sex with men for dating, etc., as 2 possible venues as well. And so these were the 2 graphics that we ended up using. I really like these graphics because the one on the left is very reminiscent of the way a conversation would actually take place on an application like Grindr. And then the one on the right is reminiscent of some just conversations that may take place on WhatsApp, which is very commonly used in Mexico. But these are types of conversations of like, are you looking, talking about like sexual risk behaviors, or on the right here, really talking about and asking questions about HIV prevention measures. So I think that these were just really interesting designs for our study recruitment. So the sampling for the study was non-probabilistic to ensure representation from our 6 predetermined geographical zones, where we wanted to at least sample 1,300 men who have sex with men per zone. So largely this map was representative of the map that the Batista Arredondo map had as their regions, with one key change was that we separated out the city and state of Mexico as its own region. So we had the Northwest region here in the Northwest, which was inclusive of Tijuana and Chihuahua. Over here, we have Region 2, which is our Northeast region, which was inclusive of cities like Monterrey and Nuevo Laredo. We have Region 3, like I said, which was the city and state of Mexico, which is also inclusive of the city Toluca. Our Region 4, which is the central region, inclusive of Puerto Vallarta and Colima. Region 5, which is our southwest region, inclusive of Puebla and Veracruz, and our south-southeast region, which was inclusive of Oaxaca and Cancun. So a little bit about the eligibility. To be able to participants had to identify as 18 years of age or older, ever had oral or anal sex with another man, or identifying as gay or bisexual, and reside in Mexico. The questionnaire was self-administered online through Survey Gizmo, and it included items from the American Men's Internet Survey and Instituto Nacional de Salud Pública, their national public health entity, their seroprevalence survey, and select themes from relevant Censida items. So Censida, they help drive the governmental policy that surrounds HIV. And so taking these sources of 3 different items from these 3 different sources, we tested these items among a focus group of men who have sex with men in the community to test their cultural relevance and to make sure that they, at least from the AMIS survey, translated well. and B, to test the mechanics of the actual survey to make sure that, once you click, that you get through all the survey and that the answers are forwarded appropriately. The questions focused on HIV testing, sexual and other risk behaviors, HIV care experiences, stigma, and use and interest in preventive services. And the survey took around 15 to 30 minutes to complete, so it was fairly rapid. So a little bit about the results of just how the study progressed. 105,000 people saw the announcements that we had, and 46,000 clicked on our survey link. So from those 46,000, 33,000 began to respond to our survey. And then 16,000 completed more than 70% of the survey. And then after our validation process, we found that we had a valid 15,875 participants. So you can see that in this online research methodology, that from seeing the announcement all the way down to valid responses, there is sort of a continuum that dwindles down. And so valid responses was part of it, like a deduplication process where we use IP addresses, age, education, and income to ensure that the responses that we did have were indeed valid and deduplicated. So our sample, the majority of our sample was less than 34 years of age, around 81%. They identified mostly as gay. We did have a sizable amount that did identify as bisexual, but very little of our sample identified as heterosexual. They were fairly highly educated, so only less than 0.2% had less than a high school education, and the majority of our sample had either a technical or a bachelor's degree, around 52%. The majority were insured, HIV negative, and we also had a good distribution amongst our different regions. But this was basically created through the study design or non-probabilistic. But we did have largest representations even still in our Mexico City/state region. So for more details on the methodology of this of the Encuesta de Sexo Entre, Hombres study, please be sure to check out our paper that was published in Salud Pública de Mexico. We also have some additional information on how people access the survey and different items on internet access as well. So now I'm going to give again, an overview of our study results and some of the products of our study results outside of just the methodology. So the first paper that we took on outside of the methodology was examining geographical differences in the HIV care continuum among men who have sex with men in Mexico. And this was published in AIDS and Behavior. I led this analysis with Dr. Smith as senior author. And we found that among our HIV negative unknown participants, that 66.1% reported ever testing and 43% reported recent testing in the past year. So in comparison, now we're talking about like our regions, in comparison to the city or state of Mexico region, MSM from all of the regions had significantly lower odds of ever and recent testing. Now I have here that it says minus the South-Southeast region. Now it did have a lower estimate, but it was not significantly different than the city or state of Mexico, but the estimation was lower. Among HIV positive participants, which was 1,600 participants, 83.9% received HIV counseling after their diagnosis, which is good. 61.9% were linked to care within a month of their HIV diagnosis. 42.4% received timely CD4 viral load results after they were linked to care. And only 38.2% accessed our timely after receiving their viral load results. And then currently, of those taking were 87.7%. So you see a big jump from timely progression through the care cascade, and then those who are currently on antiretroviral therapy. So our care cascade outcomes also varied by region, where higher odds of better outcomes were typically focused in the city and state of Mexico. We also saw some differences. We did a post-hoc analysis here as well, where we saw some differences on the time of HIV diagnosis on HIV outcomes. And so the reason we used our 2015 as a cutoff was because in 2015, Mexico implemented a policy that said that it was basically rapid ART. So regardless of your CD4 viral load or viral load, you could access antiretroviral therapy. And so what we found was there were significant differences in timely access to ART, where those who were diagnosed post 2015 were able to more timely access ART than those pre 2015. So among we also did another project looking on awareness and willingness to use PrEP among men who have sex with men in Mexico. We specifically focused on HIV negative, so dropping folks who were HIV unknown or HIV positive from this analysis. The preliminary results of this were presented at IAS 2019, and we are still currently under development for this manuscript. But among the sample in 2017, 54.8% were aware of PrEP. And so of those aware of PrEP, 77.6% were willing to take PrEP if free, and 52.6% were willing to take it even if they had to pay for it. And then 39.2% were aware of post-exposure prophylaxis, where only 8.2% who were aware had ever used post-exposure prophylaxis. Awareness of PrEP was significantly associated with being of younger age, having a higher education, increased income, living in the city and state of Mexico, and receiving a recent HIV test. So again, we're seeing better health outcomes, at least for HIV prevention and service access in the city and state of Mexico. Willingness to take PrEP if it was free was also associated with being of younger age. For this one, living in the central region, and increased sexual risk behaviors. So having increased number of sex partners, condomless anal sex, STI diagnosis, those were all sorts of indicators that were significantly associated with willingness to take PrEP if it were free. We later had another analysis to better understand patient sexuality disclosure and its in that experience and its association with clinical sexual health outcomes among HIV negative men who have sex with men in Mexico. And so this was published in the Preventive Medicine. And in this analysis, this kind of analysis took the current science a little bit further because the papers that have really looked at disclosure have only really looked at it as like a binary outcome. Either A, the patient has disclosed, or B, they have not disclosed. But what our paper ended up doing, and we had the data to be able to do this, was we looked at the disclosure process of did not disclose, disclosed, had a negative experience, had a neutral experience, and had a positive experience. So we were able to see how different experiences or like the feelings about that experience affected some clinical sexual health outcomes. So among our HIV negative and unknown participants, we found that 34.5% had received a Hep B vaccine, 10.5% had an HPV vaccine, 43% had recently tested for HIV, and 64.8% had ever tested for HIV. So 53.9%, the majority of our sample, had not disclosed their sexuality to their provider. And the main reason that they cited not disclosing their sexuality was due to the provider not asking or feeling it was unnecessary for their provider to know about their sexuality. And then conversely, we had 46.1% that had disclosed their sexuality to their provider. And so the reason that they said that they had disclosed their sexuality was that it related to their health issue, their provider asked, or they considered it important for their provider to know about their sexuality. So we found indeed that patient disclosure, regardless of whether it was a positive, negative, or neutral experience, was significantly improved likelihood of HIV testing outcomes. with though positive experience had the largest effects. But for Hep B and HPV vaccination, patient disclosure alone was not associated, but rather perceived quality of disclosure experience was associated with these outcomes. So not only did the patient have to disclose to have higher rates of Hep B and HPV vaccination, but they had to experience either a neutral or a positive experience. So really goes to show that the experiences that folks are having within their patient-provider communication processes are really important for these types of outcomes. Another paper that we looked at was the validation of the sexual behavior stigma scale. And so the sexual behavior stigma scale, you can see here the core items, but it really focuses on different types of sources of stigma. So whether that's through family, friends, or healthcare. And then from 8 to 13, they either have a little bit of structural stigma, but mostly just general stigma from 8 to 13. So this scale has been used at the American Men's Internet Survey and also has been implemented in sub-Saharan African contexts. And so we wanted to see if this might be valid for use in Mexico. And indeed, we did find strong structural and construct validity and adequate internal reliability amongst the three-factor solution that focused on stigma from family and friends, anticipated healthcare stigma, and general social stigma. So interestingly, 75% of, well, sadly, 75% of men who have sex with men endorsed at least one of these stigma experiences, and 60% endorsed at least two or more. So verbal harassment, discriminatory remarks and gossip by one's family, and fear in public places were the most endorsed, whereas sexual violence, gossip from healthcare providers, and mistreatment in a healthcare center were the least endorsed. And so validation of this scale in a Mexican context will offer providers, researchers, and folks in different regions the opportunity to be able to use this type of scale to better inform interventions that may address stigma to prevent HIV acquisition. One of the most recent, I think, most recently, we are currently working on a revised resubmit for sexuality research and social policy, but the team and I presented, but everybody was kind of there in support, our research project characterizing substance use typologies and their association with sexual risk behaviors. We leveraged a latent class analysis in this study, but 28.3% of our sample reported non-injection drug use in the past 12 months, and 1.1% reported lifetime injection drug use. The most commonly used drugs were marijuana, poppers, cocaine, and MDMA. So leveraging that latent class analysis, we identified 5 unique classes. The first class was no drug use. The second class was only marijuana use. The third class was marijuana and popper use. The fourth class was marijuana and club drug use. And then the last class was our elevated polydrug use. So in this study, the biggest finding was that in comparison to no drug use, participants in any other substance use in class had higher rates of engaging in condomless anal sex, sex exchange, anonymous sex, group sex, and STI diagnoses in the past 12 months. However, the largest estimates were among those in the elevated polydrug use class. So now I'm going to go over, from the results that I just presented, the policy implications that these really have. So despite having the largest proportion of participants living with HIV at 13.2% of the participants, the city and state of Mexico had the highest proportion of people living with HIV on antiretroviral therapy at 91.2%. So this definitely reaches that 90-90-90 goal that we talk a lot about with UNAIDS, though now it's kind of shifted to 95-95-95 as we progress. Also, the city and state of Mexico had the highest proportion of HIV negative and unknown participants that had ever tested and recently tested for HIV. So this could be due to more resources per capita in this region, decreased HIV and gay-related stigma in the area, better accessibility, so more testing hours and locations, better like access to transportation, whether that's being able to walk or public transportation, and is the location of the largest HIV clinic in the country. So the lack of recent HIV testing in most regions of the country is concerning, given testing is the first step to entering prevention or care continuums. So shifting resources and building capacity of current HIV resources to ensure more equitable access to HIV testing and care in regions outside of the city and state of Mexico should be considered. I also think that this introduces potential opportunities for HIV self-testing that may reach MSM in more rural areas, in areas with barriers to accessing HIV testing. Also, again, I'd like to mention that timely access to art was better for those diagnosed post-2015 versus pre-2015. And this could suggest that implemented policies on immediate art access, regardless of CD4 count, is improving timely progress through the care cascade. And that evidence-based policies that seek to improve access to HIV testing, PrEP, and ART should continue to be implemented, because it seems that if it is implemented on a national level as the immediate ART access, that these could be effective. Policies that promote rapid rollout of PrEP should also be prioritized. So in 2017, PrEP was not available, and it's only now really starting to roll out in Mexico. It first started as rollout in Mexico City, and it's starting to roll out in other regions of Mexico, but very slowly. So initiatives, we saw in the results that I presented on PrEP that initiatives that make PrEP free to access should be prioritized. People wanted PrEP. Of those 50%, like half of the sample that knew or were aware of PrEP, 77% were saying, we want PrEP if it's free. Expansion of PrEP services to other regions of Mexico outside of the city and state of Mexico are necessary for nationwide HIV prevention efforts, and making sure that each of the regions is reaching their either 90-90-90 or 95-95-95. Also, policies that focus on educating providers and patients on the importance of sexuality disclosure and care should be prioritized. This may be of critical importance for our tested outcomes, which included that HPV vaccination, Hep B vaccination, and HIV testing, but may also be important for future implementation of PrEP. How are these sorts of disclosure experiences affecting how folks are going to be accessing PrEP in the future? And then, as substance use policies can continue to evolve in Mexico, monitoring how these policies affect HIV outcomes will be important. So policies, particularly with access to marijuana, is a big one that's evolving right now in Mexico. The Supreme Court struck down some policies on recreational marijuana, allowing for marijuana to be accessed. But instead of it being similar to the United States Supreme Court, where things just become law after the Supreme Court strikes things down or writes their opinions, right? In Mexico, the Supreme Court gives their ruling, and then they allow the legislative body to then bring the legislative code up to the ruling. So we're still waiting now to see how that evolves and how the legislative branch then make sure that their legislation meets the ruling made by the Supreme Court, but is the reason why we need to continue to monitor how these decisions are affecting substance use and HIV outcomes in Mexico. So I think this also then introduces some opportunities for future research. I really think it's important to continue the implementation of the Encuesta de Sexo Entre, Hombres survey on a regular basis, to better understand changes in HIV risk and prevention from year to year. The American Men's Internet Survey, in which this essay was based off of primarily, has been going on since 2013, and we've been able to see from that data changes in different sexual risk behaviors and substance use, and it's very interesting to see and help inform policy and future intervention. So by allowing us to be able to see different changes on a regular basis, we can this can allow us to infer how policies are changing the HIV landscape in Mexico as they evolve. And it can also inform regional progress towards reaching 95-95-95 goals and shifting resources to meet those needs. And then also, as PrEP becomes increasingly available, it allows to better understand its progress and its rollout. So understanding better perhaps regional barriers and facilitators that may be improving or placing a burden on accessing PrEP for men who have sex with men. I also think that there's a lot of opportunity for intervention, adaptation, and implementation, and adapting effective intervention strategies for use in other regions to address those identified barriers in Mexico. I think this is particularly important as PrEP continues to roll out in Mexico. Some research on tourism and the impact on international HIV risk, I think, is something that could be warranted for future research. Unfortunately, the sample that we recruited were only those folks who were living in Mexico, but understanding that binational risk between the United States and Mexico, I think, is really, really important. And understanding maybe those tourism ecologies and how that has a effect on HIV risk behaviors should be further researched. And then lastly, opportunities to assess the impact of stigma on HIV-related health outcomes. I presented that research paper that validated the sexual behavior stigma scale. But now taking it one step further, I think the next paper that we're looking at doing is being able to see, are there regional differences and how is it affecting HIV risk behaviors and HIV prevention access? So I just wanted to thank you so much for listening to a little bit about the results that we were able to produce from the Encuesta de Sexo Entre Hombres study and some of my ideas and musings about where the next steps in policy and intervention may lie. So with that, I will accept any questions.
Super. Thanks so much, Angel. If anybody has any questions to put in the chat, Kim is going to help moderate. I guess I can kick us off. So if you were to have designed this study yourself rather than kind of inherit it from after someone else had designed it, what would you do differently?
What would I do differently? I would definitely have more questions about PrEP. So we had only accessed were folks aware and were they willing? But and we did have, and we probably will be presenting these in the paper as well. We did ask a little bit about like the tolerance and like cost as well. But I think we should have probably asked a little bit deeper. We were right there on the precipice of like PrEP being implemented. And I think if I were there, I probably would have maybe asked a little bit more questions around that willingness of PrEP and what may be barriers to PrEP. Specifically, side effects, because I think that's a huge barrier that in a lot of the studies around the world we're seeing as a barrier for folks in being willing to be on PrEP. And so I guess better understanding that barrier too and how we could address that head on as PrEP becomes rolled out, I think would have been really interesting. And then in the future, in future iterations, hopefully, really looking at long-acting injectables and the willingness and awareness of those. I know that we're only making one step towards just our current regimens of PrEP, but staying at the forefront of the science and understanding, are folks even willing, or like, are they aware, and would they even be willing to go into long-acting injectables?
So there's a question in the chat. Have you looked at regional differences with regards to provider disclosure?
That was part of the paper. We adjusted for it, but we did not provide those data. But I can definitely find those data for you. And I think there were, but I think we found the most stark differences in like the type of insurance that they had. So some of the folks that were part of, I think it was EMA-SASA, reported actually I think more neutral / like mean, the negative experiences weren't that like that. There weren't a ton of people that reported negative experiences. There was like around 10%, but they just did like through bivariate analyses, we did see that I think it was EMA-SASA that has some higher level of negative experiences. But yeah, I think that understanding like where people too are accessing their healthcare, whether it's like through by region or by the clinics in which that you can access through your specific insurance in Mexico is important too for even addressing policies in those specific clinics.
Can I just briefly unmute myself? Thank you so much for the presentation. I was asking because there were clearly a lot of regional differences otherwise, and that's why I was wondering whether you look at the provider disclosure. And I heard it correctly that you plan to look at stigma differences by region next, right? Just how to explain, apart from hypothesizing, but also how to explain those regional differences in the outcomes that you found.
Yeah, so a lot of these regional differences are definitely, I think it's twofold. The first is that a lot of policies are driven through state by state. So we have like a lot of ability to say, oh yeah, national policies should be driven like this, but a lot of some of these policies that do influence HIV outcomes and outcomes for just being a gay man in Mexico are influenced state by state. And then also not only just having the policy, but then the regions or areas and whether they will enforce the policies and how well they enforce the policies. So I think it's those two things are twofold. I think kind of following off of Steph's question, I think that would have been another really good thing to have as well, as like understanding how folks feel about like the policies and whether they feel like they are actually being enforced in their areas. But yes, I think that those policies, those types of protections and policies are influencing the regional differences, and also the resources that are granted to each of those regions for HIV prevention and care.
Okay, it doesn't look like there's any more questions. So I just want to thank you on behalf of the CFAR for presenting your results. It's great to see, and you've been super productive, and we're always happy to see when that arises from pilot grants from the International Corps. Thank you and congratulations.
Yes, thank you, everyone. Yes, and if you're interested in looking at specific outcomes in the data as well, you can definitely email Dr. Laramie Smith, and we can talk about data sharing sorts of things. So that is available.
Great, thanks very much, Angel, and good luck with the rest of your work.
Yes, thank you so much for the invitation, and nice speaking with everyone.
Thank
Great.
you.
Thank you. Bye-bye.